And hello to everyone. It's a pleasure to be here with you this afternoon. Hope everyone's having a good day. It's been having a productive conference thus far. We're very pleased to be here. My colleagues will introduce themselves in turn as we get into our session. One additional housekeeping beyond having the cameras and microphones muted is we will try to answer a few questions during the course of the presentation, but we will definitely have a Q&A at the end, so please stick around until then. And I'll be trying to monitor questions that you can pose in the chat as we go along. Thought we'd just start off with a little bit of history and introduction to the Gordon Center for those of you who might not be familiar with us. I can get control of my slides. There we go. The Gordon Center has been around for nearly 50 years, founded by Dr. Michael S. Gordon, a well-known cardiologist and medical educator. Those of
Ross,
you who
sorry to interrupt, but are you going to share?
You should be seeing this already.
Okay, go ahead.
Everyone else is seeing the slides? Yeah, we see it. Okay, good. Dr. Gordon, as many of you who have been involved in SSH probably know, won the Simulation Pioneer Award a number of years ago at the IMSH meeting that was held in New Orleans. I think it was 2015. But you may not know that besides being the inventor of Harvey, the longest standing mannequin in health professions education, he also was a pioneer in what we now call interprofessional education and other areas more broadly of health professions education. We have three divisions: the Pre-Hospital Emergency Training Division, run by Dr. Yvette Matola, who will be joining us shortly. The Division of Educational Technology Development is the one that I'm involved with. And we have our Division of Multi-Professional Health Education. I'll turn it over to Yvette to speak a little bit more on some of our Gordon Center programs, just briefly.
Great, and thank you so much, Ross. Welcome, everybody. It's great to have you here. I was going to say this afternoon, but you may be in places where it's either morning or night, so wherever you are. So I'm going to talk just a little bit about what we do. And I think one of the things that's really interesting about our center is that we do really a big diversity and wide range of things, as many sim centers do. But one of the things that, that we do, because we got our start with a cardiologist that invented a simulator way back in the 1960s, you know, we're unique in that way, and that we also do engineering development. Another way that I think we're unique is that we do, for a university-based simulation center, we do quite a bit of EMS education, but we really train all disciplines across the healthcare spectrum, and from students to experienced providers. So we do quite a bit of curriculum development, usually based on needs assessments, multidisciplinary education and interprofessional education. We also develop our own multimedia and do a lot of assessment and outcomes research. And in that area, we also do research to evaluate educational technologies. You know, so we love technology, and because we're in simulation, but we are always asking, you know, does this technology actually help improve learning? And then another area, which is one of our missions, is to really share what we've learned. And that's part of what we're doing here today. And we do that through instructor and faculty development, through courses, through presentations at conferences, et cetera. And probably the biggest one of those is our initiative with Weiser in Pittsburgh, which is our ISIM course. And we have several of those focused on both general simulation principles, but also assessment and debriefing and research. And then collaboration, which is where all of you come in. So we know we can't do these things alone. And so we have collaborative endeavors with really all kinds of different people and agencies and institutions across the simulation spectrum.
You know, result of all of these wide-ranging programs is that we have a truly worldwide impact. It's listed here, more than 2,000 medical centers worldwide use our programs in some fashion, be they having the Harvey simulator or using some of our e-learning programs or teaching with our curriculum. So with that little bit of background, we're going to go to the main portion of our session, which is about virtual or remote simulation and how that can complement face-to-face learning. Obviously, the COVID era has driven many of these innovations, but we're also looking at how we're going to continue this as we emerge from the pandemic. So first, I'd like to introduce Ms. Samantha Sims. She's the director of our standardized patient program at the Gordon Center, and she's going to talk about web-based OSCEs and standardized patient encounters.
Thanks, Dr. Scalise, and welcome, and thank you for everyone who's joining us today. I'm sure just as many of you, last year threw us for a loop when we were first told we needed to shelter in place and had to quickly adapt to remote training. So I'd like to take a few minutes today to share our process for developing web-based SP encounters, the technical steps involved in administering tele-OSCEs, and the lessons we've learned along the way. Again, Dr. Scalise mentioned, my name is Samantha Sims. I am the director of the SP program here at University of Miami Gordon Center. I use she, her pronouns. Next slide. Thanks. Early on, we identified a need to lay the groundwork for web-based encounters for SPs and developed a telehealth protocol. Some areas that we addressed were connectivity, such as verifying whether SPs have a strong and stable internet connection, the appropriate attire for online sessions. Some cases require a gown, whereas some may require casual attire. We also discovered a need for an alternate method of communication with our SPs. We tried Teams and text for communication, but neither one of those really worked. Right now, we're using WhatsApp as it can be utilized across all mobile devices and only utilizes a Wi-Fi connection, which enables us to relay our messages instantly. For encounters that do not simulate a telehealth visit and instead take the place of an in-clinic visit, it may be appropriate for the SPs to use a standardized virtual background in which we provide to our SPs. We also shared with them best practices for lighting and screen presence, in addition to how to ensure proper audio quality. So after preparing our SPs with this protocol and trained on their respective cases, we then developed a virtual session workflow to mirror our pre-COVID sessions held here in person at the Gordon Center. This diagram depicts a session workflow of how our learners, shown on the left, and SPs, shown on the right, enter and leave our Zoom meetings. This particular figure shows a formative session in which students work in trios or groups of 3. Though this workflow for higher stakes one-on-one OSCEs follows the same process. Similar to our in-person sessions, we meet with learners and SPs prior to a session to orient them. In a crunch, this session could be managed by one person, but we learned that it's best to have 2 staff members to run these sessions. One to orient the students, while the other serves as the host and manages the breakout rooms, while the orientation occurs to create a seamless experience for our students. Once the breakout rooms are ready, the rooms are opened and students are sent to their encounters with their respective SPs. Once the encounter ends, SPs complete their evaluations while students return to the main session room and prepare for their next encounter. I should note that this is only a piece of the overall puzzle. Next slide. So this diagram, although it's hard to see on screen, shows the comprehensive picture of how learners and SPs flow in and out of breakout rooms. This model allows us to get through a greater number of students in a shorter amount of time. And for our formative sessions, this model allows for each student in a group of 3 to be both an observer and an active participant for one SP encounter. For a higher stakes multi-station OSCE, instead of working in groups, each color group would signify a different student. This process allows for a variation in patient case, so students are presented with a different SP scenario in each room. Some technical features that we learned to use that improved our workflow were the timer, which must be enabled by the host, as well as announcements that can be broadcast into the rooms also by the host alone. So in order to standardize the encounter, it's also possible to control the amount of time participants are given to leave their breakout rooms to mitigate additional time given to students once the encounter has ended. Next slide. So other operating procedures to note that are important to ensure a smooth OSCE experience are these notes for our SPs. So this chart demonstrates the process for SPs prior to the start of and throughout their formative OSCE. We first expect all SPs to gather any documents needed for the session from Microsoft Teams. Next, we'll ask them to log into Zoom using their licensed account at least an hour prior to the start of a session. At this time, we'll check their audio and video settings. We will hold a final orientation to answer any case-related questions or questions that they may have about the session. During this time, SPs are trained to rename themselves in Zoom with their case name and their actual initials in parentheses, which helps the host to determine which SPs to send to which breakout rooms, adhering to the schedule. As students begin to appear in the waiting room, SPs are instructed to hide their image by stopping their video and placing themselves on mute. This allows the SPs to remain out of sight from the students until the encounter begins, much like in the center. The encounter begins once the students and SPs are sent to their breakout room, in which a timer will appear in the upper right-hand corner of their screen. Once the session ends, the SPs are asked to leave the meeting to complete their evaluations, while the students and faculty convene in the main meeting room to conduct a large group debrief if necessary. Next slide. So similar to our formative OSCE workflow, this is an example of our higher stakes OSCE workflow. It has a few additional steps. During this time, the lessons that we learned here were that we currently task our students with verbally listing the components of a physical exam. And the SP in turn would either share their screen with physical findings to simulate a findings card that they would have in the center, or we have trained our SPs to verbally relay the physical findings to the student at this point. We have learned that we need extra training time to train the SPs using phonetic spelling. Once the encounter ends, we ask the SPs to leave the meeting to convert their video and offer them a video upload guide in order to demonstrate the process for uploading their recorded videos to our LMS. While this seems like a streamlined process, as we all know, there are technical details that are learned along the way. We learned that if an SP were to leave the meeting voluntarily or involuntarily, the host must allow record once they re-enter the meeting. The host must also ensure that the recording icon appears in the participants list so that the recording can follow the SP in and out of their breakout rooms. And we also learned that in terms of recording, it's best for SPs to store the recordings locally as opposed to a cloud so that they can upload them into the LMS once the session has ended. For those SPs that are not so tech savvy, we do have a plan in place where we have a partner SP that follows along in the session to record and share the screen on their behalf. Next slide. So while we're learning daily, our processes as well as the technology constantly changes. One thing is for sure, web-based encounters and remote learning will be a permanent fixture of medical curricula going forward. It's important to revise the workflow on a case-by-case basis dependent on the need of a particular OSCE. Collaborating with software developers, we are now collaborating with software developers to streamline our process to enable SP programs to focus on development, diversity, and the training, as opposed to the tech savviness of SPs, which limits your available pool. And with all of these things in place, by doing so, we're hoping that programs are able to broaden their SP pool for web-based encounters. At this time, I'd like to open the floor to a couple questions. I see in the chat, can you state again why MS Teams did not work for you? So we did trial MS Teams and we found that Zoom has greater capability and control in terms of mirroring the in-person sessions. So in terms of orienting students, having the one-on-one interaction with SPs and students in a breakout room, and the recording capabilities, as well as sending announcements into the rooms to let them know when they have 5 minutes remaining. You may now begin the encounter, things of that nature. We found that Zoom works best for our purposes.
Sam, you have another question about Zoom and whether it's better for debriefing.
We personally have found Zoom to be more beneficial, but again, I think if you're debriefing in a large group, any teleconferencing platform can work. But for our purposes, we found that Zoom works best. Okay, we will have an opportunity to take more questions at the end, but at this time, I'd like to pass it over to my colleague, Dr. Yvette Matola.
All right. Hello again, everyone. And as Sam said, we are going to take questions at the end, so don't worry if you still have questions. We are going to tag team this next part between myself and Al Brotens, who I'll introduce a little bit at the end. My name again is Yvette Matola. I'm an emergency medicine physician by training. I've been doing simulation education primarily for the last nearly 14 years now. And I became the assistant director of the Gordon Center a few years back. My interests are varied, as are most simulationists and emergency medicine physicians, but some of the things that I'm most passionate about beyond all emergency medicine related training is really team training, helping teams be effective, communication, leadership, et cetera. And we do quite a bit of that. But I'm going to speak today specifically about one of our programs and the challenges that we faced when the COVID pandemic began, and then how we addressed those, because we thought that there were some good learning points for other simulation centers and other programs around this. So I'm going to speak about our Advanced Stroke Life Support course. And that course has actually been around for quite some time. It was developed back in 1998 and by a consortium of neurologists, emergency physicians, paramedics, nurses, as well as educational experts, which is usually the way we develop many of our curricula in collaboration with multiple subject matter experts. And it's appropriate really for all healthcare providers that are involved in the management of acute stroke patients. And it's nationally accredited by both the ANCC for nursing and the CAPC for EMS credits. The program is disseminated through a train the trainer program and a training center model whereby we train instructors and then they align themselves with the training center and go on and teach, similar to many other classes from the American Heart Association or ATLS or courses of that nature. And most of our training centers are either hospitals or healthcare systems, EMS or fire rescue agencies, or sometimes in some states in the US, it's been departments of health. And we have other models as well. Next slide. And so we have around 127 training centers, and this fluctuates depending on how many are active. And obviously, again, I'll talk a little bit about during COVID, but there's obviously been challenges to continuing training in many areas. And at any one time, we have around 1,000 to 1,200 certified instructors that are teaching. And the program is both throughout many states in the US as well as other countries in the world. Go ahead with the next slide. And just to give you an idea of how many healthcare providers were able to train with this program, looking at the last couple of years, we're in the 8,000 to 9,000 healthcare provider range that are trained every year with the program. And again, that's done through the training centers. So we train some ourselves here, but the majority is done through our network of training centers. Go ahead with the next slide. And the course is divided, as are many of the 8-hour courses, into didactic lectures, but then we also have several both interactive sessions as well as simulation practice sessions. And so when the pandemic struck and we were trying to figure out, how are we going to help and support our training centers that are in harder hit areas do this, we really had to start our wheels training and churning. And the practice sessions are usually done with SPs for neurologic exam, simply because the technology is not there yet for most of our mannequin-based simulators to be able to do things like facial weakness or arm, leg weakness, and things of that nature. We have some other interactive components, which are video case workshop, mostly focused on the EMS providers, whereby they try to identify whether a patient's having a stroke syndrome, and then we focus a lot on communication with the receiving hospitals as well. And then we have an interactive review game at the end of the day. Go ahead with the next slide. And so with when we looked at what we needed to figure out is, we figured out obviously that the didactic sessions could be done online in a virtual format, but then we needed to figure out how we were going to do the practice sessions that are usually the hands-on components, the video case scenario workshop, and the interactive review game. Go ahead with the next slide. And so, obviously what were some of the challenges that we faced? So the majority of learners for the stroke course are practicing clinicians. So that in itself, of course, posed a challenge, especially in areas that were hard hit. And also, so many clinicians were asked to do more than ever before. And I want to talk a little bit about just thanking all the healthcare providers and workers that are on this call, but also all the simulation educators that have, worked through this huge challenge that we've all faced for the last year. So the other thing is, of course, during the pandemic, that training became a low priority for hospital systems and EMS. Again, most noticed in areas that were hardest hit, and that plays into the regional variations. We realized in coming up with solutions that we had to have different options and different solutions depending on what was going on with COVID locally, and what was also going on with either lockdowns or laws and rules around any particular geographic area, because those varied throughout the country and the world. And so we had some TCs that were able to continue to train in person, and then some TCs that had to stop altogether, again, either due to local healthcare demands in the hardest hit areas or pandemic shutdowns. And then one of the other challenges that we had was new instructor training. How do we continue to bring on board new instructors to be able to teach the course? Go ahead to the next slide. So what we did in thinking through this, and then also looking to see what other agencies and organizations that do similar courses did, we did a little legwork here, and we basically opted to give our training centers 3 different options in which to run the course. We value the hands-on portion of this. We think it's a really important component, the simulation piece, but we had to really be flexible with this. And so obviously those that could continue to do the customary 8-hour in-person course went on to do that. And we've had training centers that have been able to do that throughout the pandemic. Most places have gone onto one of the virtual options or have gone back and forth, again, depending on what's happening locally. We then gave the option of a hybrid course, which included the online interactive didactics along with having their learners come in for the face-to-face portions of the course in which they practice, or doing a fully virtual course. And this is the one we kind of angsted the most about, because we really wanted that face-to-face, but we knew we had to give the option for places that were, where rates were really high, or they just weren't allowed to do training. There were many hospital systems where they weren't allowed to do training, that was considered too risky for their personnel to have that additional face-to-face time. And so we gave the option of the online interactive didactics plus remote review. And, we let them use really any platform that allowed them to do live training. And we had a whole range of them. Zoom was obviously very common, but so was Microsoft Teams, HealthStream. They used all kinds of different options. Go ahead to the next slide. And so the other things that we had to do was then figure out how do we support our training centers in doing this. And so, normally our assessments are not done online. So we had to place our assessments online. And the way that we did that was we either let the LMS, I had the TCs put it on their own LMS if they had one, or we place it on our LMS for those that did not have it. And their learners would access our LMS for pre and post testing. We had to make course videos available through a way that they could, download them and incorporate them into their online learning platform, whichever they were using. And then develop remote teaching of skills sessions with videos. And this is one that took, a little bit more work. So we had additional videos that we had created on how to teach the neurologic exam that we gave them access to so that they can do and really try to get as much remote practice as possible for those that couldn't bring in their learners. And then we developed agendas to support them and timing for each of the 2 new courses. And then, of course, because these were variations on an existing course, we also had to submit variants to the accreditation bodies with basically these new hybrid or all remote courses. And then the other thing to think about that we often forget is just all the additional administrative support required. And, we definitely asked a lot more of our administrative support team when it came to this program. And, luckily we have an amazing team that stepped up, as well as our web support team. Everyone had to do different things to really bring this together and make it successful. Go ahead with the next slide. So the other thing that I wanted to talk about, which is not specifically about our ASLS program, but just an opportunity that came out of all of this, was that we were able to partner with the American Heart Association to create a course that's called Stroke Care during the COVID-19 pandemic, which is an all online course, but it uses an adaptive learning format. So you can go through the course quite quickly if this is information you already know, or take a little more time to learn if it's information that's not. And that course is actually available through the American Heart Association. It's completely free of charge. So if you have healthcare providers or learning or wanted to add something to your simulation center that you can make available, this is just an opportunity and a positive thing that came out of all the challenges that we had during the pandemic. And I'll end by saying that we, obviously our training has been down when you look at all of our training centers during the pandemic for all the obvious reasons, but we've still been able to train hundreds of learners. So we're in the low thousands, not the high thousands for this past year. But we had around 350 learners that participated in either an all virtual or a hybrid learning course during this time. So it allowed our training centers to continue to do some kind of training, similar to what we had to do, right? Was to become creative in how we did this. Go ahead to the next slide. Yep. So now I'm going to pass it on to my colleague, Al Brotens, who is our Director of Training Operations, to talk about how we continue training during the COVID-19 pandemic here at the Gordon Center.
Thank you, Dr. Matola. And I want to also reach out to everyone and say welcome. And again, reiterate what Dr. Matola said. And thank you all for those that are in the healthcare industry and have been involved during this pandemic in whatever role you play, because this has really been challenging for everyone, and trying to remain safe, take care of patients, and run programs like we do here at the center has been really something that is brand new and taxing and overwhelming at times, but we have gotten through it, and we will continue to get through it because we have good leadership among all of us. So I'm very fortunate. My name is Al Brotens. I'm the Director of Operations Training. My background is in fire rescue. I actually retired last year after 32 years as a chief down in the Keys, and I've been with the center for over 20 years. And one of the things that was challenging is, imagine now your boss coming and telling you, we have to transition over to a hybrid model of learning. And how do we do that? And we need to do this, by the way, today, and get this done in a timely format. So looking how we reduce operations and moving all the training to, for all the learnings to remote learning in hybrid version was something that we put our heads together and started looking what were the top programs. One of the things that was really great, I thought, was that the American Heart took the lead in allowing for virtual training options for those that still needed to get their AHA certification, even though the American Heart did extend the certification process, but there were still a lot of departments that needed to get this done. So by June, we started implementing processes and procedures with obviously filing compliance here at the university in an effort to hold increased in-person training. And we looked at all we had available to us and everything that we needed to do. So to continue most of the training as hybrid and minimize in-person and hands-on skill simulation components, we looked at what would work best, what were the best models out there, and what can we do or develop as well. Next slide, please. So we immediately looked at the capacity. Well, what was our capacity and what do we need to reduce it to? So we went from a 6-to-1 instructor-student ratio to a 3-to-1 to now, after almost a year, 4-to-1 instructor ratio, which was very demanding and taxing because now we needed additional instructors. The other thing is that we developed all of our syntax and faculty and all of the COVID-19 procedures that we developed here at the center. And we'll kind of go over that in the next couple of slides. And then we looked at the hybrid courses that we needed to pretty much start creating. And those were obviously a lot of the AHA courses, a lot of the in-house curriculum that we developed here. What we did is we went through and looked at our most seasoned instructors that felt good. I'm sure a lot of you have done this type of training on the web. Sometimes you're comfortable, sometimes you're not comfortable teaching in this type of format because it is brand new. So those that were seasoned instructors, like the colleagues that are here with me today, we put together all the training that we needed to for the hybrid type courses like the ACLS, the PALS, our acute coronary syndromes course, in an effort to get this moving forward. We then posted this on our learning management system platform that we use. And then once the learners completed the didactics, they were to come into the centers to complete a skills review. Similar to what the American Heart does with their heart code courses, which you take online and then you go to a center for a skills review, we kind of follow the same format. But this whole approach allowed us to train close to 4,500 learners, and believe it or not, in a short period of time, because this kind of took off in June, and between June and December, we had to do something that normally it takes us the whole year to train, and we were able to accomplish that in somewhat of a timely fashion. Next slide, please. So this is more or less the learner checked-in that we developed for our center, along with the procedures that the university had to even come into the building. Learners lined up accordingly. We were spacing them out to the social distancing guidelines. They would come in, they would review the questionnaire. We would take their temperature. They would turn in whatever documentation they needed prior to coming into the course, whether it was the pre-test or any type of course completion certification. And then they were monitored again, and they were assigned a seat because we use it for tracing purposes later. And I'll explain that one in our next slide. So then we had them follow a blueprint that was set up throughout the entire center with their flow. Kind of like, I use the analogy, if you've been to Publix, you know that they have arrows, you can only go up and down each aisle. Well, we did the same thing here. We followed that kind of format to allow for flow and not have people moving back and forth between each other. So they had an entrance into the auditorium and they had an exit out of the auditorium, which also took them back out of the center completely. They would have to come back into the check-in point if they needed to come back into the center for whatever reason. This allowed us to make sure that we didn't have folks wandering around areas that they could not actually enter into. Next slide, please. So inside, this is another showing of where they would go. We had all these signs throughout the center, which dictated to the learners where they would have to go. And in the auditorium, we went from a 90-seat auditorium to a 45-seat auditorium, spacing the seats out in between and actually assigning a number to each seat. what we did then is as they registered, they would get a seat assignment. And then the lead instructor would then add whatever group numbers were going with that instructors to a particular station, so that we had a way of tracing that student with that instructor. If for any reason someone came back and tested positive and we were alerted, we had a way of tracing the students and the instructor quickly and making sure that everything that needed to be done was done. This helped minimize having to contact everyone that was in the building at that time. It kept a real focus on each learner and each instructor and their whereabouts as well. Next slide, please. So what we did as well is we trained all of our simulation technicians and instructors on when they get to the station, things that needed to be done. And as you know, one of the big ones was the use of PPE. Just like in the hospitals, we also encountered the same situations where we had to figure out where we were going to find a lot of the PPEs that we needed, such as gloves and surgical masks, because everyone was required to come into the skill stations with these items, and trying to maintain a stock and readiness for these items was also something that we had to work hard with to make sure that everyone had this and everyone was using them as well. So all the stations were prepped. Gloves and sanitizing equipment was used on the mannequins. There's a little picture of the mannequin in the back. We also decided not to dress the mannequins. That way we can immediately sanitize a mannequin and not have to constantly use scrub pants or scrub tops, and just minimize the context that we had. Next slide, please. And the other thing that we did, in a way, it's kind of identify where each learner would position themselves. And if you notice, this is a 3-to-1 with the instructor ratio. This way we kept the social distancing that we needed. We allowed for them to do whatever skills they needed to do in that station and work together with the team leader to run the simulation for whatever point they needed to. The instructor and the team leader working side by side to make sure that all the procedures were being followed correctly. Next slide, please. And then the big one also is now we're using electronic testing, like I'm sure a lot of you are. And so handing out the tablets, making sure that they were sanitized before they were handed out, that they were sanitized at the end of each learner's use. We didn't have them at the stations by themselves. We would literally give them to the learners every time they were ready to take either their pre-test or their post-test. That way the tablets weren't being used for any other reason, and gloves were being used during that time as well. And at the end, the staff would collect them, sanitize them, and put them back in their area to charge accordingly. Next slide. And that's what I have for right now. Again, this was a challenging time, but I think COVID did bring all of us what was going to happen in the next 5 years within the last 6 months. I think we all got there. So thank you for the opportunity.
Yeah, and to answer, I think we have a couple of questions here. I think someone asked about regarding skills sessions. Did we use any physical equipment to make remote learning possible, like sending skills trainers out to students? So we didn't for our stroke course because we use SPs. What we did was really try to simulate the simulation, right, and have our instructors would normally or SPs would normally basically act out the stroke syndrome. And so we asked them to try to do this remotely with their, whatever learning system they were using or whatever platform they were using, and still go through the identification of the stroke syndrome and then discussion about the management of the patient, which is what we would normally do in person at the Sim Center. And but it's a really good question. And it's something we've definitely considered for other courses if we weren't able to bring folks into the center. I think we were really lucky in that we didn't ever completely shut down, but we came close to completely shutting down early on. But within a couple of months, we were really able to restart training in person here at the center. And yeah, the other thing is that we also sent pictures of the face for the different stroke syndromes while people were masked. That's what we did when they did it in person. So our administrator just reminded me. So we had them have pictures or made available pictures of the different face components. So if they were doing it in person, they could stay masked and still be able to see what it would look like to have a facial droop or things of that nature. So again, just getting creative with how you do this either in person to maintain the safety, social distancing, masking, or remotely. And Al, there's a question about did we end up using the numbering seats of the seats for contact tracing?
Right. So we actually did at one point have to contact 3 individuals and that had tested positive, and we were able to successfully contact everyone that was in that group. So that system really does work well, and it's just making sure that those students stay with that instructor throughout the entire day, as opposed to in the past where we would rotate from station to station. They would stay with that instructor, and if they had to go through different stations with that instructor, they would do that at that time. So that helped minimize that the impact of changing instructors. So we stayed with that, but it does help with the contact tracing. The other thing I did want to add was regarding sending out any type of way of measuring skills. One of the things that we were prepared to do with a center that we provide training for was to send out kits for BLS skills review so that they can complete the BLS course online, and then we would Zoom meet with them and send them out a package that was FedEx and sanitized prior to getting there, and they would ship it back. It was prepaid and everything, so that then we would sanitize it and get ready for the next group should they needed that. And that was another system that we looked at doing to help other entities that needed this type of training to be completed.
Great. And I know there's a couple other questions. We'll definitely answer them at the end or in the chat so that we can move on to our colleague, Dr. Ross Scalise, who you met at the beginning and is going to do the next session.
Yep, and so this will be a nice follow-on, I think, from both Sam's and Al and Yvette's presentations, where Sam was mostly talking about pure virtual, converting our formerly face-to-face OSCE assessments into a all virtual or remote format. And then Al and Yvette talking about one great example with ASLS of how we then combined elements of face-to-face with virtual, kind of getting the best of both worlds. Just a little bit about me. I'm a general internist by clinical background. I've been here at the University of Miami in my 20th year, and here at the Gordon Center for about 18 years, where I now direct the Division of Educational Technology Development. Part of the jobs in that division include actually manufacturing and distributing the Harvey simulator and continuing ongoing technology development with that system, as well as the accompanying e-learning programs. And I'm going to reference those because we were well positioned to convert many of our curricula into all online offerings initially at the very beginning of the pandemic, and then to keep some of those aspects as we move to more hybrid formats. So, and I also kind of, you heard a lot of the nitty gritty, right? There's the conceptualization of these things, remote, hybrid, face-to-face. Then there's where the rubber meets the road is actually implementing these programs. So you saw a lot of the detailed planning and the procedures that need to be developed, the various protocols, both from Sam and Al highlighted those. So just to kind of review, with our traditional face-to-face courses, the advantages were, if you're up in front of the class, you can read the room, you have all the body language, you can connect, I think, individually with people in a way that you can't quite do looking out at, a bunch of little 2x2 video screens. So there's potential not always for greater interactivity, especially in large group type of teaching. Sometimes there's the danger of that reverting to passive learning where the students are just there in the audience and it's kind of unidirectional. But face-to-face, you have the opportunities, if you plan for those things, to optimize interactivity. And of course, one of the real advantages is the ability to do things hands-on. So some of those things are not just cognitive learning objectives, they are psychomotor skills and so forth. And that's really impossible to do in the virtual format, or very difficult to do. And so that's where face-to-face really has its advantages. Of course, limitations, which was the reality. We didn't even think about it, but we had a certain classroom size. So we could only have so many people for certain courses. The photos that we have here are, I do a lot of clinical skills training in the areas of cardiology and neurology. And, so our cardiology classroom, we could seat 40 people originally. Now in the COVID era, we basically had to cut all of our capacities in half because we would only go every other seat to keep at least 6 feet of distance. So we are limited by that. Also, people wanted to take one of our face-to-face courses, they had to come to Miami. And so that really limited the access to some of our training opportunities here when we were doing them strictly in a face-to-face format. And for our courses that say run over a month, I'm thinking about medical student courses or things like that. If a student was out sick or had interviews going on a particular day and they missed that session, that was it. If you missed class, you didn't have that learning opportunity. It was kind of a one-time thing. Of course, remote or virtual courses have their advantages. In that case, when we switched to all online back in March of last year, I had an online class of 200 students. Suddenly, we weren't limited by the fact that they had to come to Miami to take our course. People had heard about our various curricula and had wanted to take them, but just couldn't swing it to come here and do a month-long externship or something like that. Now we could open that up to people anywhere in the world. And we actually had a few students from overseas taking our courses. I gave them E for effort for being online, sometimes in the middle of the night, their time, when we were having classes here. And again, the size was not constrained by the physical classroom space. And by recording things, we are able to offer the students to see those presentations on demand. Limitations, of course, are that the hands-on activities are very difficult. They can do some practicing themselves at home, but early on in the pandemic, many students were actually fully isolated. They were living alone, and so they didn't even have one person to practice their physical exam skills, for example. And the interactivity is not zero, but more limited. And I'll talk at the end about some of the use of technology features that can try to enhance that interactivity, even in the remote environment. Hybrid courses really can take the best of both worlds, leverage the advantages of face-to-face and virtual. One of the things that is important to keep in mind is to match the competencies with the teaching methods. This is a fundamental educational principle, right, of curriculum alignment. And so it makes sense that if we think about KSAs, knowledge, skills, and attitudes as kind of the big ways we could divide competencies. It's the knowledge things, the cognitive things that make sense for the virtual environment, right? That's kind of a no-brainer. And to reserve the skills or things that really require psychomotor, hands-on type of practice for the face-to-face components. Even once we were able to let learners back in, then it didn't really make much sense to expose them to increased risk of being in close proximity with other people, to have them sit through lectures anymore. And this idea of the flipped classroom, which has been around for some time, but really can be applied in these hybrid formats, I think, to maximum effect and also yield to greater time efficiency. So we previously had some courses that were, say, a 2-day course, a mix, blended learning, some didactics, which we would do in a lecture format or small group didactics, and then hands-on skill stations. Well, we could front load and have a lot of the cognitive things be done as pre-learning on their own time. And then when they come in, you can utilize less time, but more efficiently to really maximize all of the skills acquisition part. So for some of those cognitive competencies, having a learning management system, some form of LMS, and other technology solutions can help you to utilize those things. I'll give you some examples. We have a cardiology elective that we offer for senior medical students. Previously, those were face-to-face. So again, they were only people who could come to our course here in Miami. It was primarily our own medical students and some other visiting students doing externships. When we switched to an all online format last spring, we were able to take a lot of our content, put that onto our learning management system. Here's a little screenshot. We use two different forms. Blackboard is the official University of Miami LMS, but because we have some non-university students who weren't able to utilize our institutional license on Blackboard, we also used Moodle, which is a free learning management platform that you may be aware of, open source. And so we were able to open that to students from a vast variety of schools. And then many more of them started taking our courses last spring. We also had the advantage that our Division of Educational Technology Development had already created some e-learning programs to accompany, for example, the Harvey system. So what we call UMedic is our umbrella term for our e-learning suite. We were able to just allow them to have streaming access to those via the LMS. So I don't know if you can see, it's a busy slide or a busy little screenshot, but down this left-hand navigation column at the bottom, essential ECG, essential cases, arrhythmias, those are some of our UMedic cardiology programs that students were able to access really anytime, anywhere. And then when we would do those were for asynchronous, self-regulated learning. When we would come online for our live sessions with an instructor there, we would then focus on applying the knowledge that they gained from doing this self-study, going through the clinical reasoning process. And then later in the year, when we were able to allow some in-person return, we were then able to say, okay, now you can come back and just spend your time here, not in a classroom hearing lectures, but focusing on the hands-on skills practice, for example, with our Harvey mannequin. And then we're able to give them feedback in person. These are just some screenshots from our various e-learning programs in cardiology. We have a very analogous structure in a neurology elective that we offer and that I'm involved in teaching. Again, we have all of our course business is conducted online. They have access to recorded lectures, as you can see here, for each day with accompanying handouts, either as PowerPoints or PDFs and so forth. And a lot of this can be done asynchronously, self-regulated time. Then when they get together with me online, we focus on applying that knowledge, giving them problems to solve and so forth. And when we were purely virtual, and the neurologic exam is one of the main objectives of our course, what I had them do when we couldn't come in for in-person skills practice was to do that at home. If they didn't have someone, if they were in complete isolation, some students got very creative and made their own little mannequin just by stuffing a shirt and pants and going through the motions of the neurologic exam on a patient. And what I had them do, this generation of learners is very adept at doing selfies and things like that. I had them record and upload a video of them performing the neurologic exam. I could give them feedback. They would do their own self-assessments using an online checklist, and in small groups, in breakout rooms on Zoom, they would also show their video to their classmates to get peer assessment. Again, some of the neurology UMedic e-learning programs that we have that really enabled a lot of this self-regulated learning to take place. So even here, we're all on Zoom together. Those of you who have been using it are familiar with some of these things, but the chat function can be very useful for keeping some degree of interactivity even in this remote environment. Screen sharing, people, again, it's not just sharing your PowerPoint slides from the instructor, but I would have students share their videos of themselves doing the neurologic exams. Using the breakout rooms was also another great way to enhance interactivity. And I took it as a remedy for the isolation that many of us and our students and instructors alike felt during especially the early days of the pandemic. I grouped them into small groups from their own school so that they had some chance for some socialization, even though it was virtual. Using an audience response system or the polling function on Zoom is another way to enhance activity and make sure that the students aren't just passively there listening to somebody lecture. They have to answer questions. It gives me feedback on who's getting it. If I see a large percentage of the class got it wrong, then I have to do a better job of explaining and so forth. And those same tools actually, when I thought about it, reflect fundamental educational principles. Ronald Hardin, some of you may know, he's a guru of medical education, the father of the OSCE. He talks about being fair to your learners. If you can incorporate these 4 features, you're going to enhance the learning that happens. So again, opportunities for feedback. We can do that through chat, through audience response system, and so forth. Activity, again, not death by PowerPoint, as you see in this photo, where everybody's falling asleep. We always make them have their cameras on, and sometimes I still do see people going, but engaging them, using the polling function, just the act of clicking the button, reading through the answers, typing into the chat box, that will keep them more engaged and make it active learning instead of passive. Trying to individualize and make it relevant. In our healthcare teaching, I think that's a lot easier by presenting cases that are common things that they're going to see or important clinical entities. I think that immediately brings some relevance to them. So that's where I was going to wrap up and open. I see that a number of things have come in through the chat here, so we'll have an opportunity to ask you or any of my colleagues some questions in the last few minutes that we have.
So I think there was one question at the end of Al's and mine presentation, but probably it's applicable to all of us, which is from Ibrahim, asking about whether we compared the 3 teaching and learning techniques. I think he was talking about our ASLS and the 3 options that that we gave, although he may be more broad than that. And I think, what I take away from this is sort of the same thing with my kids in virtual school. There's opportunities and there's challenges. There's some things that we definitely enjoy doing, and are more effective to do in person, right? When you're trying to practice skills with feedback and do deliberate practice. There's some of that you can do remotely, but it's definitely easier to do in person. But it allowed us to continue to train where otherwise we may not have been able to. And then we were able to see each other without wearing masks because everything in person involves masks, so I think those are some of the benefits. I think overall we received positive feedback from the training centers that we're conducting the different types of training, and we're really glad to have the flexibility and options. And, some folks we're expecting to be training in person when we started this year, but moved on to virtual because they really weren't able to based on what was going on locally. And then I think for our hybrid courses, that's been sort of the best of both worlds. I think busy clinicians value their time, like all of us, but really value their time. And I think pulling them from the clinical area for something that they may be able to do online, especially if you can make it interactive, and then, just come in for the skills, sim, team training components, that's worked out really pretty well for us. But I'll have, anyone else that wants to add to that answer.
I would share with you also, I'm sorry.
No, go ahead, Al.
I would share with you also that making the students feel comfortable and safe when they come to your simulation center is also key, that they know that we're taking every precaution to make sure that they are in an environment that's conducive to learning, and at the same time make them feel safe. So having all those things out there to show that we're sanitizing, that we have everything in step for them, is also key. So always making sure that they feel comfortable.
And I guess I'd add that although, and Sam kind of mentioned this, although we were kind of out of necessity had to move in these directions, I think we now see that there are clear advantages. I'm not imagining us going back to classes that have a lot of sitting in your seat listening to a lecture, when you can kind of front load a lot of that. And, you know, again, today's learners, they would much as soon watch on their phone a pre-recorded video lecture, and then come in and use your time more efficiently. The things that really have to be hands-on, that's when you bring them in for the face-to-face stuff in your center.
Yeah, and I think, oh, sorry, go ahead, Sam.
I was just going to say, I would echo that as well, with the advent of telemedicine and how it's just taken over. I think in terms of SP encounters, we can look to using web-based encounters more often.
Telemedicine's here to stay. I think even once we're through the worst of the pandemic, I think in our clinical practices, there's still going to be a lot more telemedicine than ever occurred in the past. I completely.
Yeah, agreed. I think it just, despite all of the challenges, it really sort of, pushed us forward, something that may have taken, another decade to get to, really has just catapulted us forward. And I think one of the things that we realized, we participated in a research study for the DoD looking at how they can maximize the limited number of instructors. It was actually one of the pictures that we had there, to reach more learners. And so we did an augmented reality teletraining for chest tube, and it was an instructor teaching remotely. And as a question that was asked, you have to obviously be able to get your task trainer, your simulator to the learners. But if you can do that, you really increase your reach with limited number of faculty and instructors. And I think that's another benefit with using whatever it may be, teletraining, telemedicine, and all the platforms that we're doing. And so again, we really found some great opportunities in all of the challenges.
So I'm seeing Olivia online with us now, and I think we are at our time, a few minutes past, in fact. So I've shared our email addresses here. Please feel free to reach out with any questions. Sometimes as soon as you hang up after a session, oh, I wish I had asked that. So feel free to reach out. We'll also be at our booth on the industry days on the subsequent Wednesdays from now through the end of March. Thanks everyone for your attention, and enjoy the rest of the conference. Stay safe.
Stay safe, everyone.
Thank you all.